So virtual service is not something we used very much prior to COVID. And it was during the COVID that we've discovered that actually there's a lot of things that we can do virtually. And one of those things was looking at the images that can be obtained in the community and look at the and discuss the findings with patient in front of the computer when both patient and I can look at the images, discuss what the findings are. The images themselves, something that we call OCT, so optical coherence laser tomography, gives a lot of information, and it's a bit basically like a biomicroscope, which takes a cross section of the back of the eye, giving us very high resolution, both en face and cross section image of the retina. And this is not suitable for every condition, but for a group of conditions that we put into vitreomacular interface, vitreoretinal interface conditions such as macular holes, epiretinal membranes, vitreomacular traction. These are conditions that we could easily assess on the OCT scans. The only additional information we would need is a small summary from the optician. So the patient would still need to go and see their optician, but then a doctor could discuss the findings of the optician and take them to the next level in terms of the need for further surgery or observation on or what the other treatment options are. And there's certainly been a big very positive feedback from the patients in terms of the minimizing the time spent on travel. Well, obviously during the COVID, it was also the safety aspect of avoiding the hospital environment, and also for people with poor mobility or those who live quite a distance from the hospital, it's been a huge advantage. And from our perspective, in the NHS setting, it was minimizing the number of people who get in contact with people. But in the private setting, it's also this can be done at the time that is convenient for patient and in a place that is very familiar and comfortable for them. So the most common conditions are the ones that involve the very center of the back of the eye. So there's a bit of the eye that we call fovea or macula, and that is the bit where there's a highest resolution cells are positioned, so we call them cones. And these cells allow us to read small print, see the color, recognize faces, and see straight ahead when we look at things. And it also coincidentally one of the most commonly affected parts of the eye as we get older. So there's a condition called age-related macular degeneration, which people may be familiar with. And the same area is also affected by conditions such as macular hole, epiretinal membranes, which is wrinkling at the back of the eye, and vitreomacular traction. So macular holes is when there is a breach in the continuity of the retina, and essentially there's just a hole in the area that we call foveola. So this usually presents as a blind spot in the center of your vision. So you would be able to see most things and find your way around, but when you look at someone's face, there will be a gray spot. Occasionally, people may not be aware of it if it's a non-dominant eye. And the way you will know which eye is dominant is if, let's say, it was a man, then they would close the non-dominant eye for focusing when shooting. And if it's a lady, then they may close non-dominant eye when putting a needle through, threading a needle. So, but most of the time, people usually are aware of it quite early on. And one of the important things about the macular hole is that the earlier it is treated, the better we know the results are. So in the early stages, in the first 6 months, the success rate is as good as 95 to 97%. The longer we leave the macular hole, the worse the outcome becomes. And in holes which have been present for longer than 2 years, the outcome can drop to as little as 60% success rate of closure. So the early recognition is important. The second condition is epiretinal membrane, and that is something that we call a wrinkling at the back of the eye. There's several variants of names for that. There's several names for this condition, and one of the lay terms is pucker, but essentially it's just a very fine membrane of fibrous tissue that has grown on the back of the eye, usually as a result of collapse of the gel at the back of the eye and release of very few cells, which then turn into a scar tissue and cause contraction in the area that we call fovea. So the symptoms that patient will present with is usually distortion. So if you look at a straight line, it will appear a bit wavy. In some people, so if we look at the cross section of population, then something like quarter of population aged over 70 will have the separate membrane, and the incidence can increase with age. So the treatment for that depends on how severe the membrane is. In the very early stages, when the visual acuity is very good and the symptoms are very mild, it's best to just observe, because not all of them progress. And but if patient find themselves closing one eye in order to see because of the distortion, and if vision is impacted, especially if patient is driving, then the surgical treatment will be recommended. And the third condition is the something that we call vitreomacular traction. That's when there is attachment of the gel to the retina, and attachment is so strong that it wouldn't separate and cause a bit of sort of pool on the retina. So we would be able to see that on the OCT scan in the cross section of it. And if there is significant traction causing swelling at the back of the eye, then we would certainly offer the operation. So treatment for all these conditions is very similar. We do vitrectomy. We peel the membrane at the back of the eye, either epiretinal membrane or internal limiting membrane, which is a very fine structure on the surface of the retina. And that usually releases the traction and addresses the problem. Well, the human contact is certainly is not there. We would be able to see patient virtually, like we're seeing you just now, and that probably is almost as good as being in the same room, but maybe not quite as same. And of course, I will not be able to re-examine the patient, so I will rely on optician's measurement of visual acuity, pressure, and examination of peripheral retina. But the accuracy of the OCT scan for the assessment of macula is very high. So there's certainly not going to be any impairment of the quality of the macular assessment. Well, it is appropriate for most patients who have problem in the macular area. It is not appropriate for patients who have problems in the periphery of the retina, which are very difficult to examine with imaging, with the standard OCT imaging. And for those patients, we will need to assess them with slit lamp, maybe even lie them down and press on the corners of the eye to examine the very peripheral parts of the retina very thoroughly. But for those who have normal peripheral retina and problem is just at the back of the eye, the virtual service is appropriate.